My name is Courtney Landine, and I'm going to be talking about pulmonary embolism. So to start off with, we'll have two questions. A 72-year-old Caucasian female presents to the emergency department complaining of sharp pleuritic chest pain, dyspnea on exertion, and cough. Vital signs are blood pressure 134/78, pulse 106, respirations 22, temperature 96.7, and oxygen saturation 94% on room air. Physical exam reveals a trachea that is midline, symmetric chest expansion, rales without rhonchi or wheezing, normal S1, S2 without murmur or gallop, benign abdomen exam, no varicosity, cyanosis, clubbing or edema of the extremities, no erythema or rash of the skin. 3 weeks ago, the patient had a total knee replacement without reported complications. Tests in the emergency department included troponin I, CK&B, EKG, and chest X-ray, all within normal limits. What would be the next most appropriate diagnostic test? A. D-dimer, B. A VQ scan, C. A pulmonary MRA, D. A CT pulmonary angiography, or E. A pulmonary angiogram. Next, a 54-year-old Hispanic female recently diagnosed with a low-risk idiopathic PE, pulmonary embolism, was started on low molecular weight heparin yesterday. What is the correct treatment for her condition given that she has a low bleeding risk? A. Rivaroxaban 20 mg daily for life. B. Inferior vena cava filter placement. C. TPA infusion. D. Emergent surgical embolectomy. Or E, begin a 5 to 7 day bridge to warfarin and continue for at least 3 months. And you can see my explanations on the discussion page on Blackboard. Now to get to our history on our case study. We have a 65-year-old African-American male with a past medical history of hypertension, arthritis, gout, pulmonary embolism with DVT, and tobacco abuse of 50 pack years. He presented to the emergency department yesterday complaining of right-sided lateral chest pain, which began 5 days ago. It's sharp and it's pleuritic in character, and it gradually worsened. He's had this pain before when he was diagnosed with his initial PE and DVT in 2009. He apparently was treated with Lovenox and Coumadin and with a maintenance treatment of Plavix. The patient was non-compliant. The patient reports cough productive of white sputum, shortness of breath, dyspnea on exertion, and chest pain, as well as edema of the left lower extremity. The patient denies fever, chills, sweats, hemoptysis, wheezing, orthopnea, nausea, vomiting, diarrhea, abdominal pain, lower urinary tract symptoms, loss of consciousness, or headache. Vital signs are blood pressure 132/84, respirations are 20, pulse is 87, and temperature is 96.7. The patient is alert and oriented ×4 and in non-apparent distress. Cardiovascular, we have a regular rate and rhythm, no murmurs or gallops. Chest, we have decreased breath sounds and prolonged expiratory phase, few soft rhonchi at the right greater than the left, and few rales. We have another benign abdomen exam. Extremities are warm without tissue breakdown, cyanosis, or clubbing of the nails. There is trace edema in the left lower extremity. For labs and imaging, we have a PT, INR, CBC, BNP, cardiac enzymes, and a CMP, all for the most part within normal limits. However, we have imaging. We have a chest X-ray, which shows interval haziness of the right mid-pleural space, which is present since 2009, and we have venous Doppler of the right upper extremity and bilateral lower extremity, which is negative. Also, we were lucky enough to get a CT angiogram, which showed chronic severe pulmonary emboli, smaller in size compared to December 2009, and a chronic area of fibrosis or pulmonary infarct in the right upper lobe. And I have these images for you, and I'll show you them now. So now we have assessment. Number 1 is chronic pulmonary embolism. Number 2 would be pleuritic chest pain. We need to rule out a new pulmonary embolism as well as bronchitis or focal pneumonia. 3 is tobacco abuse, 4 hypertension, 5 osteoarthritis, and 6 is a history of gout. Our plan first is to start bronchodilators. The one of choice is Duoneb. 2, sputum culture and sensitivity. 3 is going to be starting azithromycin. 4 is starting anticoagulant therapy. We're going to start with Lovenox. That's an initial treatment. We'll talk more about that later. Now for what is a PE, in case you didn't know. It can be total or partial occlusion of a pulmonary artery or its branches, and that can be due to a clot or adipose tissue, gas, amniotic fluid, or even secondary to sepsis or to a tumor or cancer. Also, we have 250,000 hospitalizations in the U.S. per year that have a pulmonary embolism diagnosis, and 1 in 1,000 pregnancies also have a pulmonary embolism involvement. Another high-risk group is orthopedic surgery patients, and an intermediate risk group is gynecological and urological surgical patients. The most common cause of a PE is a DVT, or deep venous thrombosis, of a proximal vein, and very often in the surgery patients. And now we'll talk about anatomy. So this picture has quite a few things labeled, but basically what I wanted you to notice was the large blue trunk in the middle. That's the pulmonary trunk, as well as it branches to the right and the left pulmonary arteries and then continues branching. Any of those passages can be blocked by pulmonary emboli. So to get back to a little pathophysiology, we have Virchow's triad, which has 3 parts to it. 1 is venous stasis, so you're not moving. 2 would be endothelial injury, that can be trauma or surgery. 3 would be a hypercoagulable state. There are a lot of those. There's genetic conditions, one of the most common being factor V laden, which is a thrombophilia. You also have oral contraceptive use, hormone replacement therapy, cancer, etc., etc. So some risk factors, I just listed you some, but to reiterate, age over 60, limited ambulation, surgery, cancer, pregnancy, smoking, history of thrombosis, and that's just to name a few. So some of the most common symptoms, the most common is dyspnea. It's present in 82% of cases, followed by chest pain, cough, syncope, and hemoptysis. Some physical exam findings include tachypnea and tachycardia. Also, you could have a pleural friction rub or rales. And there are other signs including those of right ventricular failure and signs of DVT. Also, there are 3 types of PEs. There's massive, submassive, and low risk. And you kind of divide those based on cardiac function, the worst cardiac function being a massive PE. Some diagnostic tests. First off, our differential is really broad. It could be pneumonia, myocardial infarct, aortic dissection, COPD exacerbation, and the list goes on. But the first thing you want to do is a pretest probability. There are 2 ways. There's the Wells or Geneva score, which basically you take risk factors and apply a number to give a person a score. With the Wells, a number of less than 2 indicates low probability of a PE. In that case, you want to do a D-dimer test, because if this test is negative, then they definitely don't have a pulmonary embolism. In the case where they have moderate or high probability of a pulmonary embolism based on the score, you may not want to do a D-dimer because it is not diagnostic. You may want to move on to other tests, such as a chest x-ray. There are several signs that can be indicative of pulmonary embolism. There's Westermarck sign, which is a lack of vessels distal to the emboli. There's Hampton hump, which is a triangular wedge-shaped opacity which goes out to the pleura. There's Fleischner sign, which is the dilated pulmonary arteries. And then several vague signs, atelectasis, pleural effusion, and hemodiaphragm elevation, to name a few. Next we have the test of choice, which is CT pulmonary angiography. The only downfall to this really is that it uses an iodine contrast. In the case where you can't use iodine contrast, there is a VQ scan, or the ventilation perfusion scintigraphy. And you use this when the CT is not available or contraindicated. Next, we have pulmonary angiogram. It's the gold standard, but it is invasive, so it's used less often. Medical treatments, we have a lot of options. First of all, before your diagnostic testing is through, if you have a high probability of pulmonary embolism, go ahead and initiate treatment. Our first lines, we have 4. We have the low molecular weight heparin, we have Atrixa, we have heparin and rivaroxaban, the last being both initial and a long-term treatment. So for the first 3, you want to start warfarin as early as the first day you begin the initial treatment, and you need at least a 5-day bridge where you're giving warfarin and the initial treatment. You want the INR to reach between 2 and 3 for 24 hours also before you discontinue the initial therapy and move on to just warfarin. Our other option is thrombolytics, such as TPA. You want to use this in the case of a massive PE or submassive PE in someone younger than 75 with a low bleeding risk. Also, just keep in mind contraindications with pregnancy, absolute contraindications for anticoagulation therapy such as active bleeding. In that case, we can move on to surgical. The inferior vena cava filter placement would be a good option if someone is actively bleeding. There are some that are removable. Also, you have emergent embolectomy if you have the surgical resources for that, and a massive PE that you are contraindicated to use thrombolysis, then you can go to emergent embolectomy. Lastly, there's the catheter-based intervention, which is basically for refractory cases where you can't use thrombolysis in a massive PE. Some preventative steps are early ambulation following surgery and compression stockings. And so basically all you have is keep moving and prevent that venous stasis. Also, complications and prognosis, they vary greatly on the presentation. A massive PE has a mortality rate of 50%, while a non-massive PE has an 8 to 14% mortality rate. And there's actually an index score with lots of different variables you can use to calculate an individual's mortality rate. Common complications, pulmonary hypertension is the most common. 1 in 25 PE patients get it, and it's due to having a chronic thromboembolism. You can also get recurrent thromboembolism and heart conditions from the thromboembolism, such as right ventricular failure, and treatment-related complications. We are using anticoagulation therapy, so bleeding, hemorrhagic stroke. There's also heparin-induced thrombocytopenia if you're using heparin, and the list goes on. For education, for patients with idiopathic or recurrent pulmonary embolism, VTE, DVT, you want to do an appropriate cancer screening because it is one of the main causes of a hypercoagulable state. Also, while patients are on anticoagulation therapy, you want to be sure to check INR, APTT, or even anti-10A. In the case of low molecular weight heparin, you want to make sure that these drugs are in a therapeutic range and they're not increasing bleeding risk. Also, if the patient is on warfarin, they need to be educated on their diet. They need to have a constant vitamin K. They don't need to be changing that too rapidly because it can affect the drug and their risk of bleeding. All right, that's it. If you have any questions, leave them in the comments. Thanks.